Okay, well, thanks, Sarah, and thank you all for being here this evening. I guess I'll start out just with a quick shout out to our surgeons. I know Sarah gave a really neat talk on the practical approach to managing tumors as they walk through the door, and we're very blessed to have surgeons with the talent of Sarah and David here. They certainly can work a lot of miracles. My whole philosophy, though, in managing cancer is that it really is a multidisciplinary approach for many different reasons. It's seldom that just surgery, just radiation, just chemotherapy is going to result in the best outcome. So it's usually some kind of combination approach. And obviously here in Sydney for many years, there hasn't been an option for radiation therapy. So I'm here very excited to let you know that we can now present a full service radiation therapy program for your patients and clients. And you may already have had some inkling of this as the years go by. You know, people see their pets more and more like children, parts of the family, that kind of thing. And certainly in my practice, it's not uncommon that they come in really wanting and expecting the highest level of care that is possible. So this is a presentation really which, as it says, it's enhancing veterinary cancer care over and above what has been available. And again, not without there being an established program through the years that you guys have had experience with, I'm going to start out the talk just with a brief introduction to what radiation therapy is. We'll take a look at some of the more important radiobiology principles behind decision-making paradigms in these treatment regimens. We'll look at the types of radiation therapy utilized in veterinary medicine today. Some of the tumor types that are applicable for utilization of these therapies. And then we'll kind of round things off with a few interesting case-based studies just to bring some of the principles home. So, okay, we'll get started. So radiation therapy essentially is a treatment of cancer, and I could throw in there other certain non-malignant conditions with ionizing radiation, so high energy photons and electrons. And these particles have their effect by inducing DNA damage. That's either directly affecting the DNA strand or indirectly through an interaction with a water molecule, which generates your hydroxyl free radicals, which then go on to have a DNA damaging effect. And this requires a high oxygen tension environment for free radical generation. And the higher that oxygen tension environment, the more free radicals are formed, the more damage to the DNA occurs, and that's likely to be irreparable, which is beneficial in tumor cells, not so much in normal cells, and we'll elaborate on that. So the unit of radiation dose is the gray. This is a unit of absorbed dose. It's defined as 1 joule per kilogram of tissue irradiated. And the basic goal of radiation is the delivery of a measured dose to a defined tumor volume, resulting in minimal damage to the normal surrounding tissues. Unfortunately, radiation doesn't discriminate normal from cancer cells. So in these high doses, we will have killing of cells either via mitotic or apoptotic cell death mechanisms, or in addition to that, we can also see sterilization of rapidly dividing cells, so these cells that will lose their replicative potential. And ultimately, though, it's the normal tissue response that limits how much radiation dose we can deliver to a tumor site. And this raises the concept of the therapeutic index, which is similar to what you would deal with any pharmacologic agent. And it's defined again here as a tumor response for a fixed level of normal tissue damage for any given dose. So these cartoons down here illustrate that pretty well. We have two curves, a toxicity curve and a clinical effect on tumor tissue curve. So for any given dose, the wider this therapeutic window, the more successful the outcome, because you can essentially give a higher dose with limited toxicity to the patient. Conversely, here you can see as that window narrows, it's a little more problematic. You're less likely to get tumor control without more serious normal tissue complications. And the goal ultimately is to aim for less than 1% of serious complications. These are defined usually as bone or soft tissue necrosis. Okay, so this brings up the 4 R's of radiation. It's one of the fundamentals of radiobiology. And we can, with some understanding of these mechanisms, manipulate things to our advantage. There are a couple of them that are actually detrimental to therapeutic effect. And obviously, that would be repair of DNA damage. And that can occur in a whole host of mechanisms: base excision repair, nucleotide repair, mismatch repair, those kind of things. Fortunately, normal cells have a greater capacity for repairing this DNA damage than do the cancer cells. And the other one that may affect efficacy of therapy is repopulation. So a very important proponent of any biopsy report is the mitotic index. It gives you some idea of how aggressive and actively dividing these tumors are. As we're treating these tumors and killing cells, the obvious problem is if they're repopulating the tumor volume as quickly as we're killing them. So we have to be cognizant of our intertreatment intervals. We don't want them to be too prolonged and allow for these high mitotic index tumors to repopulate. On the other hand, we can see an increased efficacy of therapy through redistribution through the cell cycle. So what has been well established is that cells that are in the S phase of their cycle are relatively resistant to the effects of ionizing radiation, and that's largely because of very high levels of DNA repair enzymes being present in that environment. In contrast, the M phase is highly sensitive. So as you're cycling through, with fractionated treatments, you will eventually get cells that are in the M phase that are more sensitive to the effects of radiation. And then lastly is reoxygenation. And we can think of this in 2 separate components of chronic hypoxia. So the obvious or classic example, I should say, here is the big, bulky tumor with that necrotic center. It's just basically outgrown the blood supply in the central portions of this mass. So that's a problem because, as we've discussed, we need this high oxygen tension to generate free radicals to have the effect on these the DNA of tumor cells. So as you start shrinking these tumors down, killing outer layers of the tumor, it's easier for angiogenesis to occur and reach those central areas, eventually increasing the oxygen tension to a level that is effective for hydroxyl creation. And then we also see acute hypoxia. That can be moment to moment, day to day, under the constraints of different variables like nitric oxide levels in the blood and things like that. But you can get temporary vasoconstriction for a whole host of reasons that could affect your oxygen tension, and that's going to change moment to moment. Okay, so different types of radiation currently utilized in veterinary medicine. Brachytherapy, these are some examples. So interstitial placement of cesium and iridium seeds and beads, or radium beads. Usually it requires the surgical implantation of these tubes, and then you have to have one of these what are called afterloading devices. It's just a well-shielded machine that these sources are in and can be pushed through these tubes and inserted directly into tumor beds. It's not widely utilized for various reasons, but it is still used in people for certain things like prostate tumors. It has been used in cats and horses, probably most commonly in horses at the moment. By far the more common form of brachytherapy employed is plesiotherapy. Sarah mentioned a little bit about cats with early squamous cell carcinomas on the planes of their nose or tips of their ears. So this is a very effective method to treat early squamous cell carcinoma. Systemic forms of radiation is radioactive iodine, so your hyperthyroid cats, as in this example here. And then samarium, it can be used for primary bone cancer care. I think there's only currently one place in the States doing this. It's in Missouri. But the bulk of this talk, and certainly the bulk of radiation treatment in veterinary medicine, really centers on teletherapy. Back in the day, that started out with orthovoltage machines. My understanding is there's one of these active in the Melbourne area. This is an example of it. It's basically generating relatively low energy photons in the range of 100 to 300 kilovolts. And it's useful for some superficial tumors, but not really for anything at depth, brain tumors, spinal tumors, jaw tumors, things like that. You get too much skin reaction trying to treat with this type of equipment. So then came the advent of cobalt machines, which have also fallen out of use. This is an example of an old cobalt machine. And now, more typically, linear accelerators, of which there are multiple generations. I'll show you some of the newer ones later on in the talk. But it's basically much higher energy photons, between 1 and 20 million volts. It's more deeply penetrating radiation, but it does have a relative skin-sparing effect. Okay, so probably the first question to answer when a patient walks through the door with a tumor is what your goal is, what outcome you're shooting for, whether that's curative or palliative intent. And that centers really on the expected prognosis, the probability for long-term survival, where we might employ a curative intent, even though we may not actually, in the ultimate end, cure the patient. We refer to it as a curative intent therapy regimen. As opposed to our palliative intent, extended periods of survival are not projected, but there still is a great benefit to the patient in terms of pain relief or functional improvement related with tumor obstructions, and I'll show you some examples of that a little later on. As I mentioned earlier, cancer care is really a multimodality approach, and it's always a great thing working with a team of people which come at this from different angles. So we have a lot of daily communication as to pre versus post-surgical radiation, and there are advantages and disadvantages to both. So just to run through some of those things, the things that cross our minds each time, because there's no one size fits all. Each patient, each tumor does require a individual deliberation. So we have here for pre-surgical radiation, some of the advantages is we're treating a smaller field. Post-surgery, obviously, we have a scar where they've planned, as Sarah showed you, with the Sharpie marking, a wide excision field. Now we've got to irradiate that. It's going to expose a lot more normal tissue. So in certain circumstances, depending where on the body we're dealing with, it might be preferential to do the radiation first to limit normal tissue exposures. There's also some compromised vasculature after a surgery, which can, theoretically at least, this is not well studied, but it may affect the oxygen tension in those tissues and the generation of free radicals to kill the tumors. And the other advantage of pre-surgical radiation is that it may indeed shrink the tumor significantly, making it a bit of an easier task for the surgeon. Some of the disadvantages are that tumors are naturally heterogeneous. They're going to have variable hypoxic zones in them, so their response to a given dose of radiation will be variable. There's also the increased potential for metastasis the longer a tumor is in situ. That again depends on the individual tumor, how aggressive it's been growing, what its mitotic rate is, etc. And it could potentially complicate the surgery due to increased wound dehiscence in previously irradiated tissue sites. By contrast, post-surgical radiation, advantages are that there's less chance for wound dehiscence. There's also minimal residual disease after the surgeons have been there and taken out the bulk of the tumor, so there's fewer microscopic clonogens that the radiation has to come and mop up, essentially. So improved potential for cure. And before the advent of some of the newer planning software, it was easier to have an improved dosimetry in a flat contoured tissue as opposed to some of these really irregular tumor shapes. But that's largely been overcome with advancements in planning software. The disadvantages are that tumors may regrow while waiting for a surgery site to heal. I've seen that with some very aggressive vaccine-associated fibrosarcomas in cats. Sometimes within a month or so, they're growing back. They may cause breakdown of surgical flaps with fistula formation, just as shown up here. And there is a chance, as Sarah mentioned, for metastasis due to dislodging and seeding of tumor cells, depending on how cautious and careful the surgeon is. Okay, so what are the common tumor types you can consider that are feasible radiation candidates? Oral tumors, actually a lot of head and neck tumors, but oral tumors in particular, things like melanomas, squamous cell carcinomas, whether it's the tongue, tonsils, gingiva, fibrosarcomas. This is an example of the histologically low grade, biologically high grade. We just treated one of these patients here 2 weeks ago. Osteosarcoma, mast cell tumors, and acanthomatous epilodes. Those are all reasonable candidates for radiation. Central nervous system tumors, these are obviously, they can be very challenging to resect depending on where they are. Even when they can be debulked, often you would still need to follow up because of an incomplete margin. So it's more common that we're dealing with brain tumors than spinal cord, but there's a whole host of them in the spine. And then within the brain, things like pituitary macroadenomas, consideration for acromegalic cats. These are those uncontrolled diabetics on 19 units of insulin twice a day, and they're still clinical. Radiation can significantly bring that under control. Meningiomas, gliomas, those are all commonly treated. Okay, tumors of the trunk and extremities. Again, Sarah showed a lot of images and what can be done without radiation. A lot of times tumors will grow back when they're not completely excised. If an owner is not willing or able to undergo an amputation for various reasons, then radiation is the standard of care now for mopping up any residual disease, and it's very effective. So again, a whole host of tumors here that may have benefits in terms of limb salvage post-operatively. Okay, and just some miscellaneous tumors, things like thyroid carcinomas, thymomas, subcutaneous hemangiosarcomas, infiltrative lipomas, anal gland tumors, ceruminous gland tumors of the ear, salivary tumors, and even transmissible venereal tumors. So just to give you an idea that there's a real wide range of tumors that can be benefited with radiation therapy. Okay, and then on the palliative side, as mentioned, probably the big ones are osteosarcomas, where amputation is not desired or not possible. You know, you might have the presence of lung metastases and a short expected survival, or you get really obese pets with concurrent orthopedic or neurological issues that make them poor amputation candidates. The radiation not only kills those tumor cells, but it does have an analgesic effect as well. It's speculated to be via the substance P pathway that it has that analgesic effect. And then other tumors that are causing functional obstructions to the airway or esophagus or bowel lower down in the pelvic canal, you can result in significant reduction of tumor volume and improve quality of life. This is an example here of a histiocytic sarcoma in the cranial mediastinum before and after radiation. Okay, so this will bring us to a few interesting case studies, and I will say if there's any questions, it's pretty informal. Please feel free to shout out, and I'll do my best to answer your questions. But I think this will sort of bring home some of the things that we can offer going forward. So Bella, this first case, she's a 9-year-old female spayed Weimaraner with a 1-month history of ataxia and stumbling, pronounced CP deficits and a head tilt on the left side. She initially had a moderate improvement on prednisone, but then progressed with neurologic deterioration. A CT scan was done, which showed contrast-enhancing lesion in the left caudal brainstem region, and she was referred for further evaluation. Okay, at presentation, an MRI was done, and this showed a uniformly contrast-enhancing extraaxial mass with a typical sort of dural tail and a hypointense central region. As seen here, this is consistent with a diagnosis of a meningioma in the caudal brainstem. So there's not really a good surgical option for that lesion. And our plan was to proceed with definitive radiation, delivering 20 fractions of 2.5 gray, so a total of 50 gray. This is an example of a fusion study, a CT scan in this orientation and your MR in this orientation. And obviously we get much better neuroanatomic detail with the MR, but it's important in terms of the planning capacity of the software to have the CT as well. So we can fuse those studies and get really good imaging detail. So this is just illustrating some of the software capacities, generating our treatment fields in a 4-field setup. These pictorial description here is just your isodose lines in different colors that we can prescribe to the tumor. Okay, just some more examples of what we're looking at to ensure we're treating the right location. We can generate what are called digitally reconstructed radiographs. So this is based on our initial planning CT scan. Looks like a poor quality X-ray, but it's enough to give us the neuroanatomy, and we can contour in where the tumor is, and each day make sure we're lining up precisely where we want to be to deliver that dose. And this is some examples of our outcome. So before and after radiation in the sagittal and transverse views. And this is fairly typical. We tend to see somewhere between 10 and 20% reduction in the overall volume of meningiomas in dogs, which doesn't sound like a lot, but it is quite significant based on where it is. Anatomically, these are tumors that are probably growing in there much longer than what we realize by the time they get to see us. So even small reductions in tumor volume can result in pretty significant clinical improvement. Okay, and she's 18 months post-radiation, off of all medications, completely normal neurologic parameters, except for mild facial drooping on the left side. And her owner was reporting she was back to chasing around the yard catching squirrels. So good quality of life. She is one of many dogs. They've done a couple case series now published, and one of them 25 patients with survival times in excess of 2 to 3 years, and they were equally as likely to die of an unrelated illness. Okay, Blizzard is a 6-year-old male castrate Great Pyrenees, presented with a 6-week history of sturdor and sneezing, and it's pretty obvious there's something going on there. This was initially non-responsive to antibiotic treatment, and there was this rapid progression to result in facial deformity and pain, resulting in significant degree of head shyness. So CT was done, which showed an irregular contrast-enhancing mass originating in the frontal sinus and with extension into the nasal cavity. There was a biopsy done, which pretty much looked like this, large amount of criteria of malignancy, and that came back consistent with a squamous cell carcinoma. Blizzard was staged with imaging, chest films, ultrasound, mandibular lymph node aspirates, all of which were negative. Had a very highly motivated owner, because obviously this kind of stage of disease is not always ideal to take on. But we went ahead with combination of radiation and surgery for best results. That was the plan that was discussed with the owner at the outset. Okay, this is just, again, some tools available with the treatment planning. So this is showing the tumor contour relative to the skin and bony anatomy, and we can kind of peel off the different layers including organs at risk like the eyes in particular when we're setting up our plan. So there's a lot of things we can do to play around with to generate dose volume histograms, and specifically looking at dose to organs at risk relative to the target volume. So in this instance, we opted for 17 3-gray fractions, 51 gray, using a tangential wedged pair coming in at oblique angles from the side, so similar to irradiation of women with breast tumors. And here's some examples of our before and after radiation. Pretty significant tumor volume reduction. So again, before, this is about 2 weeks after radiation. This is some of the typical acute effects in the skin, what we call a radiation dermatitis. It's some superficial ulceration and crusting, and that usually typically heals up within 4 to 6 weeks of treatment. So 6 weeks later, the skin had healed up well enough, and Blizzard was prepped and taken into surgery. At this point, he was so much more comfortable. You could actually pet him on the head. He wouldn't shy away, but we knew there was some residual disease in there. So they made a frontal approach, took out the rest of this tumor here, the big cavity left there that was closed in. And again, we just have some before and after pictures. That's his biopsy before radiation. And this is what it looked like after radiation. You can appreciate how sort of necrotic this looks at this point with the pycnotic nuclei and fibrosis, as opposed to the more viable cells over here. This is him post-surgery, post-op. This was about a month after surgery. And he was doing really well. The skin changes you see here are pretty typical as well. The hypopigmentation with variable hyperpigmented regions, that's due to the effects of radiation on melanocytes in the skin. But he was a much happier dog. Unfortunately, his story didn't end there. 5 months after the procedure, he presented with a lameness in the right front limb. And you can probably make out here this irregular mixed lytic productive lesion in the proximal radius, which on aspirate was confirmed to be metastatic squamous cell carcinoma. He received a course of palliative radiation to that region, which controlled his pain for 3 months, and then it was progressive and he was euthanized. At that point, the local disease on the skull was completely controlled. Buddy is a 10-year-old male castrate domestic shorthair. He presented with left-sided purulent nasal discharge and sneezing of 6 weeks duration. This was unresponsive to antibiotics and showed a temporary improvement on steroids. So this is his CT scan, which again shows a left-sided soft tissue mass with significant degrees of bone erosion breaking through the maxilla into the retroorbital space and resulting in proptosis of the left eye. Biopsy was consistent with lymphoma. Our plan here was to treat with 16 fractions of 3-gray. You'll notice this is a bit lower than some of the others, and that's because lymphocytes are exquisitely sensitive to the effects of ionizing radiation, so you can get away with lower doses and still get excellent tumor control. His plan was a bilateral opposed oblique field setup. We used a surface bolus, about a centimeter thick bolus, and this is just to raise up the depth of the dose deposition. As I mentioned before, these high energy machines have a skin sparing effect, and his tumor was breaking up all the way to the skin surface, so we wanted to account for that. And we planned to follow up with a short course of chemotherapy. We know lymphoma is a systemic disease. So although this is a stage 1 localized disease, if all we did was local therapy, we know they fail distantly, usually in the kidneys or spinal cord or somewhere else. So this is just an example of his DRR with tumor and organs at risk contoured in. And this is his outcome. So 17 months post-radiation, he was in a complete clinical remission. This is fairly typical to see this degree of leukotrichia in pigmented patients. So again, the melanocyte production is affected by ionizing radiation. And one study out of UC Davis looking at 19 cats showed median survival time in cats treated with combinations of radiation and chemotherapy in excess of 32 months. So with excellent qualities of life. Okay, Colonel is a 13-year-old male intact Shih Tzu who had a history of a right anal sac mass excision 6 months prior to presentation. It regrew within 4 to 5 months, was resected a second time, and that resulted in fecal incontinence. Obviously back there, the sphincter muscle is critical, and it's difficult to get wide margin excision in that location. But then he started to present with straining to defecate, and a CT scan was done showing a significant contrast-enhancing intrapelvic mass. So that's compressive of his colon. Contoured in his structures, in this case the colon being the organ at risk. We were going to treat both the primary site as well as all the afferent lymphatics, as in these striped red lines going up through the pelvis and into the medial iliac lymph nodes. He was treated with bilateral opposed fields, 19 fraction coarse 2.5 grays, total of 47.5 gray. This brown structure here is just a lead block. It's a primitive form of blocking out the organ at risk, because the main issue here is circumferential exposure of the organ to radiation, which could result in late-term effects of fibrosis and stricture formation. But if we do spare half the circumference, we don't tend to see that issue. So that's what that's designed for. Okay, here's some examples of his before and after. So before and after, pretty significant tumor volume reduction. At another level, before treatment, after treatment. And at another level, before and after. So his obstipation resolved midway through treatment. And once he was finished with his radiation, we started him on mitoxantrone chemotherapy, and he did exceptionally well for the next 22 months. Unfortunately, then he started to develop a renal failure, which he did succumb from a little later on. Okay, Cappy is a 7-year-old male castrated American bulldog. He presented with a mass on the caudal aspect of his distal right forelimb, which was excised with incomplete margins and was consistent with a hemangiopericytoma. So this is essentially what it looked like. He was a pretty non-compliant patient. He got around his cone, licked and chewed, and so when he presented to me, this is kind of how his wound looked. We had to nurse him through this phase a little bit because we don't tend to want to irradiate open wounds. It does delay the healing phase after radiation. But once healed, the plan was to give 18 3-gray fractions, a total of 54 gray bilateral opposed fields. And because of where it is, you don't always need advanced imaging to do the treatment planning. So we were able to do a manual calculation based on algorithms. Saves a significant amount of money for the client. And here's some follow-up pictures. So this is at treatment number 16. What we see here is some erythema and early moist desquamation of the skin. 2 weeks after radiation, it's more of a dry crusting or dry desquamation phase. At 5 weeks, more significant alopecia, but reepithelialization of the skin has occurred. And at 6 months post-therapy, still a persistence of alopecia, but pretty healthy-looking epithelium. And he's at least 18 months post-radiation in complete remission. So surgery combined with radiation, the published data is about 85% disease-free interval greater than 5 years. So very good outcomes in the majority of those distal limb tumors that you can't get wide margins on and don't want to be doing amputations for. And I think I have one more case here to run through with you. That's JD. He's a 9-year-old male intact chocolate Labrador. Presented with progressive dullness, staring into space. This is a hunting dog, prized hunting dog, and he could no longer stand unsupported with circling and head pressing. It's really traumatizing to him and the owners. There was a mild improvement on prednisone. He presented to the neurology service for further evaluation, and the MRI showed this large, hyperintense mass effect consistent with a pituitary macroadenoma. Okay, our plan was to treat 20 fractions, 2.5 gray, total of 50 gray. We looked at two different plan evaluations, a bilateral opposed field and a 4-field setup. We opted ultimately to go with the bilateral opposed setup, and that had to do with the vertical height of the tumor and how much brain was being exposed with a 4-field setup. If I go back a couple slides, you can appreciate how big this mass actually is. So the dose volume histograms showed an improved coverage of tumor relative to brain exposure with the 2-field setup. And here's his pre and post, so before and after. And the sagittal views before and after, and coronal views before and after. So really significant and dramatic reduction in tumor volume. 16 months post-radiation, he's symptom-free. He was hunting again, working in the field. He did, however, become hypothyroid, which is a consequence of doing radiation in that region. But he was well managed with Siloxane supplementation. And one published study, pituitary masses, 19 dogs. They showed median survival times in excess of 1,400 days in dogs with radiation, as opposed to 359 days in dogs without it. Okay, and what you probably noticed is a lot of these cases are talking about fractionated radiation therapy. I do want to introduce you to a concept of something called stereotactic radiation, which we have access to here now as well, and just go briefly through some of the advantages of that. But just quickly, a couple other interesting outcomes just to visually drive home the point of how effective radiation can be. Sarah is a dog with a nasal adenocarcinoma, so this is a before and after radiation picture. This is fairly typical. What we showed actually before I came out here with the group I was at is carcinomas typically reduce about 66% in tumor volume. Sarcomas of the nose is about 33%. And so we can utilize this information, again, with counseling our owners of what to expect before and after radiation. And often we'll follow up the radiation with a dorsal rhinotomy, go in and just scoop out that residual tumor, and they can do very, very well long-term with that approach. Especially the sarcomas that don't shrink quite as much. It opens up their airways that much more, and their quality of life, I think, is exceptionally good. Okay, so just shadow. This is a dog that had a histiocytic sarcoma in the neck that we irradiated and shrank it down significantly, and that was then surgically excised. He went on to do very, very well. This is the other histiocytic sarcoma image I showed you earlier. This is a dog that came in through the neuroservice, was laterally recumbent. After 8 treatments, she was jumping up on the table for her treatments, and after treatment, pretty much melted that tumor away. So very, very good result. Plasma cell tumors, another one that are very highly responsive. Again, these are mature B-cell lymphocytes. So this is not an exciting surgical proposition, but after radiation, we can really melt these tumors away. And here's an example of an advanced stage squamous cell carcinoma. So this one is obviously not eligible for the strontium form of radiation therapy. It's too extensive, too advanced. But the teletherapy option is a very good one that can result in cosmetically marked improvement as well as comfort levels for the patient. Okay, and as I said, I was just going to talk briefly about stereotactic radiosurgery and its applications in dogs and cats. What it is essentially a single high-dose fraction given to intracranial targets. So it was developed mostly for people with inoperable brain tumors or metastatic brain tumors. And those doses are much higher than what we've been talking about, between 10 and 30 grays per fraction. It can be also given fractionated up to 3 fractions. And it's a bit of a misnomer to say radiosurgery because there's no surgery involved, but it's the precise delivery of the radiation that's important. It can have a surgical precision with how conformal these treatments are in outlining the tumor volume relative to normal tissue. And you've all heard of gamma knives and cyber knives, the Linac scalpel. Those are the machines that we're using to treat these patients. And we are utilizing a Linac scalpel setup here in Sydney. So what it is it's using multiple either non-coplanar or isocentric arcs. So that's what this image is showing. Basically the gantry of this machine spinning around the patient, while at the same time a multi-leaf collimation system in the head of the machine, 160 to 180 leaves, is bending and shaping that beam in real time as the gantry is spinning around, and it results in very steep dose gradients. So within 2 to 4 millimeters, you have greater than 50% dose fall off, and it's preserving normal tissues to a large extent. This technology has now also been extended and applied to tumors in other sites of the body, so not just the brain and the skull, where it's referred to as stereotactic body radiation therapy. Again, it's usually 3 fractions, but can be anywhere between 1 to 5 fractions. So the types of tumors we're treating with this option, of course, are intracranial tumors, meningiomas, macroadenomas, gliomas, choroid plexus tumors, and trigeminal nerve sheath tumors. And in the extracranial tumor category, osteosarcomas, transitional cell carcinomas of urethra and prostate, nasal tumors, oral and facial tumors, anal gland tumors, and things like heart-based or thyroid tumors, as well as subcutaneous and cutaneous masses. And in people, radiosurgery has demonstrated high cure rates with minimal complications. And this is the result of that high degree of conformality I was speaking about. But really, the delivery of doses it's critically important that you're delivering it where you think you are. So your imaging modalities and treatment positioning setups are critically important to the success of this therapy. So we make use of a number of important aids, things like thermoplastic masks to help rigidly fix the patient to the indexed treatment couch, bite plates of various designs with dental acrylic molds that mold to dental arcades in dogs very, very well, as well as these vaculock bags that can conform and mold to the patients. But probably most important on these advanced new machines is onboard imaging. So a CT scan, essentially, that's combined with a linear accelerator. And what that allows us to do is pre-treatment upgrade from those digitally reconstructed radiographs I'll show you to an actual cone beam CT that we can line up with the original set of images, and it's highly accurate in terms of treatment setup. And there's a significant increasing demand for this treatment option in animals because of obvious increased convenience, 3 treatments as opposed to 18. There's much less anesthesia involved, so it's less invasive for these patients. And there's a significant decrease in the incidence and severity of adverse effects. I showed you that one picture of Blizzard earlier, that typical dermatitis on the face with the fractionated form of treatment. With this option, you don't see that. It's very sparing of normal tissues, highly conformal to the tumor. So for those reasons, it's definitely increasing in demand. It's just not widely available because of how expensive these machines are, and we're very fortunate to be able to offer that here today. So with that, I'll take any questions, and thank you very much.